I suffered from, and still suffer, from Meniere's. I was incredibly lucky because I never incurred my first attack until I was 72, some 8 years ago. So I got through most of my life without the problems that I now realise lots of young people and other people have. My good friend, who was really responsible for where we sit today, Bruce, soon heard that I was suffering and suggested I might like to join and help find some relief, if not a cure, for all of us. So, of course, I did, because he's one of those determined people that don't let you say no. And thank you very much, Bruce, for all the work you do. He's an absolutely tireless chap behind the scenes. We're going to have, as you know, the 5th annual Meniere's disease research. I'm not going to say very much other than to say every dollar we receive from you and other people is spent on research. Not $1 goes towards any of the people who are involved in running this organisation. We all meet our own obligations because we believe that every dollar must be spent on seeking some form of relief. I tell you that because I know that in many other areas that I'm involved, something like 20 and 30 and 40% of whatever funds are raised are lost before they're used. They're lost for social reasons and other reasons. In our case, every dollar goes towards research. I'm now going to call on our great professor, Bill, who, by the way, I was very pleased to see he got an AO when he was moved up from his AM, and he deserved every opportunity to help us now. Thanks very much, Bill.
Thanks, Leo. Thanks, Leo, and thanks everybody for coming on such a hot day. This is our 5th meeting. We were panicking slightly because our first speaker got waylaid. So we're going to start today with Selene, who is going to, McNeil, who's going to talk about hearing aids and their role in Meniere's disease. She works at Bondi, and I go there about once a fortnight to work with her.
Okay, so as Prof said, I'm an audiologist, and I'll be talking today about hearing rehabilitation and how it helps to improve the quality of life of people who have Meniere's disease. So as you probably know, Meniere's disease manifests itself as a combination of the 4 symptoms of ear fullness, tinnitus, hearing loss, and vertigo. So Meniere's is a disorder that affects the inner ear and slowly destroys the sense of hearing and balance. So while the researchers are working in the background trying to find a cure, clinicians like me are working in the foreground trying to help to manage the symptoms of those affected. So the aim of current clinical treatment is to improve quality of life by minimizing the symptoms that cause disruption. The diagnosis of Meniere's is very confusing because there are other disorders and diseases that can also present with hearing loss, with tinnitus and vertigo. So early diagnosis is certainly the best possibility that one can wish for, but sometimes the diagnosis is delayed because it is very complex. So what can an audiologist do to help in the diagnosis of Meniere's disease? So audiologists can do diagnostic tests to help the specialist to exclude other possibilities. So we can do audiometry, we can do tympanometry, ABR, and you can also do electrocochleography. But for electrocochleography to be effective, it needs to be transtympanic, and for that we need an ear surgeon to insert the probe on the promontory to get a good response. Audiologists also perform diagnostic tests of vestibular function. We do V-hits, VAMPs, VNGs, and calorics. And we're going to have our next speaker talking about that a little bit more. So, but the most important thing I'm here to talk about today is how can the audiologist manage the symptoms of hearing loss, tinnitus, and the dizziness as well. So audiologists can coach patients to understand their condition and to take control over their symptoms. We take advantage of brain plasticity. Current theories of neuroplasticity show that the neural pathways in the brain are constantly changed and they adjust to new information, pleasant or unpleasant. So we can adapt to things. So for more of that, I would encourage you to read the work of Norman Doidge and Michael Merzenich, who are neuroplasticists that have been around for a very, very long time. But this conversation is just starting to appear in the clinic in more recent times. So it works pretty much like this. If an unpleasant symptom is normalized rather than medicalized, the reaction and response to that symptom will change and become less disruptive. I'll give an example of my great-grandmother back in Brazil a very, very long time ago when there was no weather forecast, there was no washing machines, very little medical intervention. She would welcome rheumatic pain because it was a sign of a storm coming, and she didn't have to do the washing. So you see, it depends on how you look at the symptoms you are suffering. So it all depends on your point of view. So individuals' brains are wired to respond differently to the same stimuli, depending on the experience that promotes their learning. So in that picture there, you can see two things. Depends on, has everybody got it? You could see a frog or you could see a horse, when in fact it's the same picture, just turned upside down. So if you feel dizzy and sick for a well-known reason, so you say you go to the pub and you drink your life away and you get very dizzy, very sick, are you going to the doctor? No, you're not, because you know why you are dizzy. But if you feel dizzy for no apparent reason, and you will feel very scared and very worried, and right, so you go to the doctor. But it's interesting that some people pay to feel dizzy and have fun. Other people pay for medication to stop them from feeling dizzy. Fair enough. But we also know that current medication for dizziness does not address the cause. It only masks the symptoms. So medication to sedate the brain to reduce symptoms adversely affects neuroplasticity. So we know that stress increases the symptoms of vertigo, tinnitus, which is one of the symptoms, or two of the symptoms of Meniere. So we also know that Meniere's disease is not life-threatening, but the unpredictability of the symptoms generate a constant state of stress. The person is under chronic vigilance, waiting for something unpleasant to happen. And this constant state of stress is generated by the good old fight or flight response. I'm sure we all know that response. It is a response of the body to protect ourselves from danger. So symptoms such as vertigo and tinnitus may trigger this response. And overactivity of the system leads to chronic stress. So how does the fight and flight response work? So it's a neurophysiological reaction. So the amygdala in the brain will react to a perceived threat. In the case could be you're having a vertigo attack, that's a threat for you. So the hypothalamus activates the sympathetic nervous system, releasing adrenaline. The adrenal cortex releases cortisol for continued alertness. And what happens to the body? You have pupil dilation, you have dry mouth, fast breathing, heart pounding, tense muscle, slow digestion, sweating, and so on. I'm sure all of us have experienced this in a situation or other. So, Meniere's is a disorder of the ear. And disruption to the ear, yes, cause spinning, cause tinnitus, and cause hearing loss. But disruption to the inner ear does not cause sweating, does not cause trembling, heart pounding, dry mouth, or fluid retention. So these are brain response in reaction to the stress caused by mostly the fear of the symptoms that you're experiencing. So vertigo and tinnitus are symptoms that the sufferers cannot control. And as you feel it, you get stressed. The more stress you get, the more you feel, and that goes on. And on that note, I encourage you to look at this website, seekingbalance.com.au, which is an audiologist who does a lot of work for people with dizziness and tinnitus using neuroplasticity. So Meniere's disease is not life-threatening. Living in a constant state of stress is taxing on the body and its neurons. So the person is under constant vigilance, waiting for something unpleasant to happen. If you keep calm, in control of the symptoms, the severity is not going to be as dramatic. So vertigo attacks are very unpleasant, but we know that they do not last forever. So untreated hearing loss, that's what I know about. I'm talking about a lot of things that's not my specialty, but my thing is hearing loss, and that's what I'm going to start now. So untreated hearing loss is another stressor for the body, and we know that. Unless you do not need to live in a world of sound, then that's okay. You can have a hearing loss because you're not going to have to strain to hear anything. We have a hearing. The hearing function connects us with our surrounding world. And we know that Meniere's impairs the sense of hearing. So what happens when you have a hearing loss? It will cause a lot of misunderstanding. And misunderstanding can lead to anxiety and depression. Misunderstanding also increases stress levels. Anxiety, depression increase the stress levels. Stress increases anxiety and depression. And if you already have tinnitus and dizziness, one keeps feeding the other. Yeah? So we need to break that. And perhaps if you work on the hearing loss, we could improve things a little bit. So hearing loss is the one symptom of Meniere's that we can control. Paradoxically, it's the last one that people address. Usually they leave hearing loss for the last thing. They look after the vertigo, they get desperate about their tinnitus, but the hearing loss, they don't think it's very important. People with Meniere's do not hear well on the ear that are affected by the disorder. And their hearing is asymmetric. So most have Meniere's in one ear only, and that causes what we say a unilateral hearing loss. Some will have Meniere's in both ears, causing a bilateral hearing loss. Meniere's cause asymmetric hearing again. So that means one ear always hears better than the other. Even if you have bilateral Meniere's, we usually have one ear better than the other. So what does it do in real life? When you have an asymmetric hearing loss, it's very hard to tell where sounds are coming from. When there's background noise, it's very hard to follow a conversation. Also in Meniere's disease, people are very sensitive to loud sounds. And this is because of recruitment, which is a phenomenon that happens in the cochlea. And also when you have an asymmetric hearing loss, you have balance disturbance, because say if you're walking in a very open, noisy environment and your hearing is different in both ears, you do lose your perspective of balance because the ears are giving you mismatching information. So, and the side effects of hearing loss is withdrawing from social contact. This is the biggest one. Isolation, anxiety and depression, and stress. So, there are different options available for the management of the hearing loss. One important one is to be aware and understand the hearing loss that you have, understand what you can and what you cannot hear, understand which situations you can hear with no problems and which situations you have real problems. You can ask people to speak louder if you have a hearing loss. You can use an amplifying system like we're using here now, or you can use the good old hearing aid. Hearing aids these days are very discreet. Nobody can see you are wearing them, and they come in different colors and shapes. The selection of the appropriate hearing aid, however, varies according to the stage of Meniere's. There are 4 stages of hearing in Meniere's disease as the disease progresses. So in the first stage, the hearing fluctuates in the lower frequencies only on the ear that you have the problem. So that means sometimes you don't hear low-pitched sounds, and sometimes you do. And also you have tinnitus and you have vertigo. So in the first stage, for some people, the loss of hearing, which gives that fullness sensation, the tinnitus, getting louder, may be an indicator that you're about to have a vertigo attack. So in that case, it may be worth listening to your tinnitus as a friendly reminder that an attack's coming, so you're ready. Yeah? But as a general rule, to listen to tinnitus when it becomes chronic is a bad thing. You want not to listen to that. This is just at the very first stage of the disease. So at this point, we would not consider a hearing aid because the other ear is normal and the hearing loss in the low frequency is not really affecting your overall. But it's important to learn to understand what's going on there. On the second stage, the low frequencies do not recover. The mid-frequencies fluctuate. So at this point, people start noticing, yes, I have a problem, and especially if in both ears. And if they have some other problem on the opposite ear unrelated to Meniere's, which is very common because as we get older, we do lose hearing. So hearing loss is common regardless of Meniere. So a lot of people can have Meniere's plus some other type of hearing loss. So then, if you are on the second stage, what do? We use self-programmable hearing aids, which are hearing aids that the person will program themselves at home as the hearing fluctuates. On the third stage, hearing still fluctuates, although people don't realize, because the fluctuation is not as much, not as dramatic, but there's still a little bit of fluctuation if you monitor that carefully. At that stage, a hearing aid with a volume control is quite useful because if the hearing gets a little bit better or a little bit worse, you can adjust that with your volume control. You don't need to reshape the configuration of the frequency response on the hearing aid. And then you come to the fourth stage. At that point, the hearing becomes so severe that a hearing aid won't help anymore. So cochlear implant will be the last resort. And cochlear implants are extremely successful in patients with Meniere's disease. So some people still discourage Meniere's patients to try hearing aids, and this is much based on audiology test results. There is a misconception that speech recognition scores in audiology tests predict outcome with hearing aids. And I'm going to tell you this is not true. I'll just give you an example. This patient had Meniere's on the right ear and normal ear on the left. She had the test in the clinic, speech recognition test, which is that test that the audiologist puts you in the booth with the headphones and gets you to repeat words. And you find the first time you do that on your Meniere's ears, if you had Meniere's for a very long time, you're going to find the sound extremely loud, extremely unpleasant, extremely distorted. And you're going to score very badly on this test. So in this case, for example, the lady had 40% score on that right ear. So the person who looked at that result said, a hearing aid is not going to work for you, so don't bother. We did fit this person with a hearing aid, and, hang on, sorry, I'll just go back here. We did fit this person with hearing aids, and 6 months after wearing the hearing aid and doing a lot of auditory training, the speech recognition improved, brain plasticity for you. So the brain can adjust to new signals as long as there is training, as long as there is a need and motivation for that to occur. And then looking back at this patient, if she had had a cochlear implant, she would have done just as well, but perhaps she didn't need it, okay? So what predicts results with hearing aids is the site of lesion and degree of hearing loss. We know that if the hearing loss has some neural involvement, speech recognition will be difficult, but we know that hearing loss in Meniere's is due to a cochlear lesion. Therefore, the results with the hearing aid and the cochlear implant are very good. So again, providing there is no other associated factors, such as poor cognition or limited brain plasticity, which happens as we get older. The brain is less malleable, so changes are harder to happen. So why we have, well, I have said that already, why do you have speech recognition scores that are very poor in audiology tests? Recruitment is one, because we learned that you have to put the sound at a certain level that's far too loud for the patient with recruitment that haven't had stimulation on that ear for a very long time. And this is happening because of auditory deprivation. So if that ear is deprived from sound because of the hearing loss, well, it's not the ear that is deprived from sound, it's the brain that's deprived from sound because of that hearing loss. So recruitment is a sign of a cochlear hearing loss. Loud sounds are perceived as extremely loud and uncomfortable when they are not uncomfortable for people who don't have a hearing loss. So, but hearing aids are digitally programmed to equalize sounds at different frequencies according to the individual's hearing loss. And they also reduce loud sounds. So they don't only make soft sounds louder, but they also make loud sounds less uncomfortable by compressing it. So what happens with auditory deprivation? So if you don't attend to your hearing loss for a very long time, the brain areas that receive sound will stop receiving those sounds. There will be, these areas of the brain will be used for other functions. And what happens? You start losing memory for sound, and that's when speech recognition starts to go down. So another a big thing that we see in patients with Meniere's disease, because of recruitment, they tend to overprotect that ear because it is sensitive. It's a little bit like you have a cut and you keep poking on it, yet it hurts. So, but instead of adjusting to that by stimulating the ear with sound, the person tends to put an earplug, which does the opposite. So the more you protect your ear, the more sensitive the brain will become to sound. And also, sound deprivation, we know, causes hyperacusis, which is a more higher phenomenon, like a higher level on the brain instead of at the cochlea. The person becomes very sensitive to loud sounds, but nothing to do with the damage in the cochlea, like in Meniere's disease. So we can have a person with perfectly normal hearing and hyperacusis because for some reason or other, they've been deprived from sound, for sound exposure. So don't take me wrong here, ear protection is very important, but only if in the presence of harmfully loud sounds. For everyday sounds, ear protection is not a good thing. It's a little bit like wearing sunglasses indoors. You will become very, very sensitive to light if you're always protecting your eyes. Same with the ears. So, back to neuroplasticity of hearing. The longer one lives with a hearing loss, the more difficult it is for the auditory pathways to rewire and make sense of the sounds delivered by either a hearing aid or a cochlear implant. So the brain adjusts to new signals, provided there is motivation and need. So we see a lot of people that they put the hearing aid on, they just wear sometimes, they don't want to hear, the wife or the children want them to hear, but this person does not want to hear. Their problem, their decision. So the plasticity is not going to happen if the person doesn't want it to happen. So it's you who decides, but takes effort. It's not just put the hearing aid, life is good. No, it's put the hearing aid and let's do training. Same with cochlear implants. Nobody put a cochlear implant first time and hears well. Needs training. So neuroplasticity takes place over a period of time, and sounds which initially may be perceived as distorted and unpleasant become normal with time and training. So our clinics cohort shows that symptoms of Meniere's are less disturbing after hearing loss has been addressed. So what we do as a clinical protocol, we use questionnaires to assess how much the disruption of tinnitus and hearing loss and dizziness caused in the person's life. We use self-hearing tests to monitor hearing fluctuation at home for a period of time. We use subjective scales to monitor tinnitus fluctuation and dizziness, and we fit the appropriate hearing device to improve hearing and to reduce tinnitus perception. So self-monitoring of symptoms promotes better understanding of the condition and reduces anxiety and stress. So we ask the patient, we coach the patient to monitor their hearing, their tinnitus, and the fullness, and the dizziness on a daily basis for a period of time as a learning, teaching you how to listen to your body and what's happening there. We know that our hearing test in the clinic is only a snapshot of the hearing levels at one point in time, so you can't base on the hearing test that you had in the clinic once to decide if you have Meniere's or not. There are lots of hearing apps, hearing test apps that you can use at home to monitor your own hearing, but of course that needs to be done under guidance of a professional that knows what they are looking for. So fluctuating hearing loss means that your hearing sometimes is good, sometimes it's bad, sometimes it can predict an attack of vertigo, sometimes you can't predict anything, but you need to learn that process that's happening within your own body. So as I said before, the audiologist will coach the patient to test their own hearing at home before deciding on the most appropriate course of action. And once we determine which stage of the hearing loss we are dealing with, then we are going to select the appropriate hearing aids. So the patient, when they, especially on the second stage, they'll be fitted with the hearing aid in the clinic. They'll be provided with the software and the hardware to program their own hearing aids, and again, coached by the audiologist to do that at home when their hearing changed. So that avoids that constant coming back to the clinic to adjust the hearing aid, so they can do that themselves. So management of hearing loss helps to improve the ability to hear. It masks tinnitus, reduce sensitivity to loud sound, and from what I see, minimize the impact of dizziness and vertigo, because you feel that you're more in control of your symptoms and you understand what's going on. So our results suggest that self-testing, monitoring will help the overall management of Meniere's and improve quality of life. And I'll finish here.
Thank you again for being here and also having me here today. Before I go on to talk about the particular study, what I thought I'd do is just sort of take a big picture in terms of clinical research, what we can do, what we're trying to do, and sort of cover not just the study that I'd like to present, but also future directions. And to do that, I just sort of put this question on the title slide about precision medicine. As you know, Meniere's is a disease that affects different people in different ways, and there's many symptoms, and different people present with different permutation and combinations of those symptoms. However, for the Meniere's Research Fund, the goal has been always to find a cure, but the question is that can one cure solve everybody's problem? And in the spectrum of auditory symptoms versus vestibular symptoms, I often see patients who have other comorbidities, such as they may have Meniere's as well as vestibular migraine, so they have vertiginous attacks not related to their Meniere's, and they need a different treatment. You have some patients with Meniere's who present with BPPV on the other ear, for example, and that needs treatment. Some patients have neck disease and they present with cervicogenic vertigo. Of course, stressful life events can often trigger off Meniere's, and in the last 12 months I've had three male patients who presented with their first onset of Meniere's which was brought on by the onset of their first child, the birth of their first child, and as the children have grown up, their symptoms have settled down, and I presume they will come back to see me again when their children are teenagers. And of course, poor dietary control, often stress means that there's poor dietary control. So all of these other cofactors, if they're not controlled, their underlying Meniere's may not be controlled, and in some cases there are different disease factors. So I think in the world of precision medicine, we should also be looking at customizing the cure for each patient rather than having one pill that solves every problem. So with respect to clinical research, we sort of get quite busy with all of the different studies we're doing, but just as a big picture, there's 3 large areas we look at. One is understanding the cause, diagnosis, different tests to make sure that we're diagnosing the patient accurately, and of course different treatment strategies. With the first box, the first circle, understanding cause, this is where a lot of the research that Daniel's presented comes in, because we generate a hypothesis, we test it out in animals. When it's safe to, then we move into humans, and it sort of ties into the study that Prof's going to be talking about, which is our viral study. However, the majority of research that we do, clinical research that we do, is in the realms of diagnosis, accurate diagnosis and accurate treatment. And as you all know, there's a couple of limitations. Firstly, the anatomy of the inner ear. It's incredibly inaccessible to getting information, and also disease factors. Different variation in the disease means that you can't lump a large group into one category and expect that all of those variables are going to be the same. So there's often confounding factors that dilute your results. So with this, I sort of went down and had a look at, well, we obviously need to stratify the patients in the groups that they present in. So we know that the burnt out disease patients often don't present because they don't have vertigo anymore, so they'd only usually present just for their hearing rehabilitation. So the patients who most present to doctors for help are the patients with early and active disease. And in that, there's a spectrum. So some patients present with mild disease, and so they only present intermittently. Some patients have moderate disease, and they're the ones who most often present to outpatient clinic. And then there are patients with severe disease, and they would be most likely to be presenting to the emergency department. So they'd present with drop attacks, complications such as fractured wrists, etc. And those patients often used to streamline to more ablative treatment. So in a way, they're almost easier to treat because their complaints are so severe. And in that, it's actually easier to get data as well. So firstly, if you are looking at ablative treatment, we know we've already done studies to prove that labyrinthectomy and a cochlear implant is a great outcome in the sense that it treats Meniere's disease in a way. It resolves the patient of their vertigo, but also restores their hearing. But also, this also gives us the opportunity to attain data. We can have access to their tissue, which is what the majority of the study, the content of the study I'm going to be presenting today involves. And so most of our research then is targeted to this group because they're an easier group to study. However, most of the patients don't belong to that group. Most of the patients belong to this moderate group. And they are difficult. It's a difficult group to study, mainly because a lot of these patients encountered their attacks at home. When you see them as a clinician, you're often seeing them when they're well. So the data, you may get the data at the same time as you're seeing them, but that may not correlate with the disease spectrum. So poor diagnostic data often means poor research and therefore poor treatment regimens. And I think in this group overall, the goal for us for cure should be to prevent an attack rather than resolve. So for example, in the severe group where you ablate the disease, the organ to prevent to cure them of the attack. And I do think in this group there's a lot of new technology that's out there that we can take advantage of to hopefully make this group the goal of future study. So after I present the study that we've been doing for the last 3 years, I'd really like to touch on some of these new technologies that we're hoping to engage in our future trials. So our Meniere's tissue study is a study we've done over the last 3 years, over 2 sites and 3 surgeons. And what we've been doing is when patients undergo labyrinthectomy, so we're talking about those patients with severe disease, we've been very patiently taking out the very, very friable inner ear tissue and sending that off to the pathologist to study. And of course, with any group, when you have a test group, you also need a control group, because actually there's not much data looking at the human inner ear tissue. So our control group, we thought, well, who else do we destroy the inner ear organ? And there, it was a very easy control to choose, and we have patients who are undergoing vestibular schwannoma surgery, which is a tumour of the balance nerve. To get to the balance nerve, you need to destroy the balance organ, so that was our control. And of course, the study also had an animal arm, which Daniel was leading. So over the 3 years, we collected 19 ears, that was expected, so that's why we did it over 3 years, because it's not an operation you do often. And even amongst that, we had only had 8 patients with Meniere's disease and 9 patients who were controls. Now, this is a picture, it's actually a picture I found of an operation that I did with Prof about, I don't know how many years ago now, and we were doing a labyrinthectomy at that stage. This is the lateral canal, the labyrinth that's open, and you probably, even under the microscope at this resolution, you can't see the inner ear membrane, and that's because it's clear, it's less than 1 millimeter in size, and even to take it out, we either have to hook it out or pull it out. We can't actually see it. So in that process, when we were sending it to the pathologist at the start of our study, she said, that tissue is horrible. I don't know what you guys are doing, but it's crushed. It's got a lot of artifact. So we actually then had a temporal bone session where we got some cadavers, and we all sat down and patiently looked at the cadaver tissue, and then sent that off to the pathologist. And the pathologist, of course, said, fantastic, why waste that? I'm going to study that as well. So that's just sort of to say that, yeah, we had, at the start of our study, there was an issue with technique. And also, having been one of the surgeons who was doing the study, I must say different patients have different quality of inner ear tissue. Certainly, the more elderly the patient, the more friable the tissue is. And so you can imagine, after spending a good 20 minutes trying to put a drill over the most thickest bone of your body, and to be very careful that you just stop drilling when the bone is thin enough. You uncover the labyrinth, pull it out with a hook. When you see not much come out because the tissue is so friable, it's a real knife to the heart, I tell you. But anyway, so we did, despite that, we had some good specimens, and the tests that we looked at, we just did normal histology, which is just looking under the microscope. We also did some immunohistochemistry, which is looking at antibodies that may be specific to the inner ear tissue. And that was really with the background that we had. There was some literature that had come out to say that there's some abnormality of the basement membrane underneath, and also some abnormality of the neuroepithelium, which is really saying the skin cells, the cells that are the nervous tissue cells. Now, the basement membrane, if this picture looks like a sea of pink with blue dots to you, don't worry, because it looks exactly the same to me. As a surgeon, I can tell you that, and also as just looking at inner ear tissue, I can tell you that there's not very many people who have expert in looking at inner ear tissue, because it's a tissue we have such limited access to. So obviously the person looking at this was Professor Mori, who is the director of SIDPAP at the time at St Vincent's Hospital. She's moved to Canberra, and she moved during this study, but she was so passionate about this that she still carried through, and we had to, so she, even though she was in Canberra, she still reported on this and had a look at this. So it's, in terms of basement membrane, it's really just a supporting line, a membrane that supports the skin cells. I shouldn't say skin cells, the cells of the inner ear. The aims of the study, we said, well, we don't actually have a lot to compare to, so we wanted to look at, is there, all the theories that we have at the moment, that there may be an inflammatory response, maybe there's a vascular thing, maybe there's an autoimmune problem. So we said, well, why don't we look to see if there's inflammatory cells in this tissue? Why don't we look and see what the structure of the tissue is? why don't we look at, to see what the balance cell and are there any antibodies targeted to the balance cells and also the supporting cells? And also, are there any fluid handling protein abnormalities, because it is a problem with fluid handling. So the first thing we thought, we only had, amongst all the Meniere's tissue, we only had one patient who actually had that basement membrane abnormality. And in this picture, you see that there's this sort of pink thickening behind the cells. That's the cellular lining. This is the supporting cells. And this area is called the basement membrane. But most of our patients didn't have any basement membrane abnormality. This patient was the only abnormality, and he'd also had gentamicin beforehand, so you don't know how much of the drug has influenced the results. So that was interesting, and the most important thing that Adrian with her skeptic goggles on said, look, it depends where in the whole the canal you're actually taking the specimen. Certain areas you expect the basement membrane to be thickened, and it is, but certain areas it's not. So researchers around the world have to be very careful, because they're all reporting on very small numbers. They have to be very careful about what to call abnormal and what to call normal. We were looking at degeneration of neural structures, and in our study again we didn't find any degeneration, but we have to, our patients had severe disease, so they had active symptoms. You would imagine that patients with burnt out disease would probably have more degeneration, so that was not a surprising finding. We looked at the blood vessels, and we saw that the blood vessels have very, very thin walls. Almost all they can have is, they're one cell line in diameter. And at this magnification, we didn't see any abnormalities in the blood vessel. However, around the same time we were doing that, there was another study that was released that did electron microscopy on the blood vessels in Meniere's tissue, and I must say they did report an abnormality. So I don't think we can conclusively say that it wasn't there just because we didn't look at it with electron microscopy. We just looked at it with histology, and at our level, at the magnification level, we didn't see an abnormality. I think the most unique thing that we found is that all of the supporting cells in the inner ear had this really high staining to something called S100, and S100 is a specific thing that is stained for neural tissue, but supporting tissue doesn't. So supporting tissue anywhere else in the body doesn't have that stain. Will not react to that stain. So I think the key here was that inner ear supporting tissue is supporting tissue unlike anywhere else found in the body, which is why we have to be really careful when we draw parallels. And we don't really know how much, we shouldn't say we don't know, we do know that the human inner ear will also be different to other species, and the best we have to duplicate it is in animal studies like the guinea pig, but it's still not going to be the same, which is why the clinical studies are important. And the other thing is we found that there were no typical lymphatic channels either in these patients, and that was really interesting, because when you're thinking about inflammatory mediators, you're thinking about lymph tissues. So I think overall, before I go on to that, I just thought the other things we were looking at were antibodies, and we found that again there's a particular gene we were looking for that is associated with so we were looking for a genetic cause for Meniere's disease, and there's a particular gene associated with it. We didn't find that in this area. We also didn't find that there was an abnormality of the fluid proteins, the fluid handling proteins, and we're only looking at the canals, and we got some tissue of the area called the vestibule. The only endolymphatic sac specimens we had was from the cadavers, and the cadaveric tissue is processed, so we can't do these tests on the cadavers. But I think going away from this study, I think most of what's happening is probably in the endolymphatic sac as opposed to the actual balance organ, but especially in active patients with active disease. That then brought us to, well, can we actually look at endolymphatic sacs in humans, in our Meniere's patients, and that is a very difficult thing to do. I think we can definitely look at them in schwannoma patients because by definition, by the operation, we're going into their brain. But in Meniere's patients, taking out the endolymphatic sac, which sits a little bit within the dura, there's a risk of creating a CSF leak, which then needs to be patched. And because there's a risk of harm, you always feel nervous in doing something because the whole philosophy of clinical treatment is and research is first do no harm. So I don't know if that's something that's easily, there's a tissue we can easily look at, but we definitely have to work and revert back to the animal studies to look at that area in more detail. So I suppose where to now? And this is where I sort of wanted to look at, new things we're looking at to sort of, think laterally. So what else can we do, particularly focusing on the moderate group? And this is especially in an era where diagnostic tests of hearing and balance has come leaps and bounds. So this is, for example, a picture of the head impulse test. This is Elodie, who's often involved, who's often our, I call her French model, but she's often our she's often our scientist who goes to the clinics to do the tests, and she's just modelling the VEMP electrodes just to show it's non-invasive, not painful, and hence the smile. On the right-hand side is a picture of a Wii board and some virtual reality gear. I had a MD student, we often have MD students in the office who are testing these things out and evaluating them. And my MD students' project was to look at these non-invasive tests and compare that with patients who have symptoms of vertigo and patients who have fill out quality of life questionnaires, and also then compare them with the actual tests of balance function. So what we wanted to see is what is the correlation between a complaint of vertigo versus actual abnormality. And this wasn't Meniere's patients, it did include Meniere's patients, but it was all patients presenting to clinic over a year. And we found that there was very poor correlation between quality of life score that patients were feeling and the balance tests. And that's because, as I said, with the, in the first couple of slides, there are often lots of other things going on. If you have cervicogenic vertigo, if you have BPPV, you won't have an abnormal balance test. If you have vestibular migraine, you won't have an abnormal balance test. However, there was very good correlation with all of these tests with objective measurements of balance. And now that we know that there are objective measurements that can measure not only the presence of Meniere's disease, but also the severity of Meniere's disease, and it is evolving as we speak, I really think that we need to take these tests and somehow empower patients to be able to, hopefully test it themselves at home, because that's when they're getting their attacks. So this is where, in an era of nanotechnology and 3D printing, we've been having a lot of conversations about how to utilize these technologies and come up with concept designs of little devices that we can, wearable devices that patients can use, hopefully to test as well as to treat. We've got a nano hub at Sydney Uni. We've also done a lot of work with 3D printing, and now we're doing work with bioprinting. Without going into too much detail, bioprinting is, and just to mention in the relevance of where we're up to in technology, we are able to scan anatomy of one part of a body. So my project involves scanning the ear, flicking it to the other side, and we're trying to 3D print living cartilage for patients who don't have, who are not born with the ear or have abnormalities of that ear. So if we can do that we can 3D print with living tissues, I think it really opens up to conversations such as this, where we had, a lot of conversations about in the future maybe building nano robots that can go inside the inner ear and sit there and get data. And then we sort of came into about, well, what sort of data should we collect? And we actually, back again where we actually don't know how the inner ear reacts to not just normal but also abnormal. So I think before we go on and build fancy robots, and we need to do some more animal studies to look at what is varying in normal animals and when you induce the animals with disease processes. We also, I really want to build in this whole, any device that we manufacture or design, a port of drug delivery, because I really want patients in the future not to be able to just detect their disease. They can then also be able to give themselves medications at the same time. So that would be my pie in the sky picture of how you'd go ahead and, prevent the attack of the disease, prevent the attack, and therefore help that moderate group. That's all I have. Thank you.
Okay, well, thank you for coming. And I know Professor Curthwaite is in the audience, so I'll tone down a little bit. So as we all know, Meniere disease is a clinical syndrome of vertigo and fluctuating hearing loss. And we've heard a lot from Peo and Selene earlier this morning about hearing loss and some of the new exciting technologies, which I'll expand a little bit on. Now, interestingly, the current diagnostic criteria from the Barani Society, the International Society for Vestibular Disorders, in 2015, the current diagnostic criteria actually do not require testing of vestibular function. So if you look carefully, they require fluctuation of hearing, but there's no mention of vestibular testing, which I thought was interesting. But all of us know that clinical testing of vestibular function are helpful in the diagnosis of Meniere disease. Now, there are two organs in the vestibular system. There's the canal, semicircular canal, so they sense rotation, and the two tests I've got in green and purple, head impulse test, which I'll talk a lot about today, and caloric test, which I wouldn't talk too much about today, but I'll tell you why I think perhaps there's still a minor role of caloric test. And then I won't talk too much about VAMP, but I'll mention some of the newer guidelines and findings in VAMP. Now, I think some of you may have had caloric testing, and caloric testing is, I certainly had it myself, it's not a particularly pleasant experience, but traditionally, this is the test that gets requested for vestibular function tests in Meniere disease. And as we all know, it involves putting some hot or warm and cool air or water in most places in each ear, and then you compare the response from each ear. And about 50% of Meniere's disease, the caloric test is abnormal. Now obviously that figure depends on the stage of Meniere disease, whether you test them shortly after an attack. But that's an average figure. Now, this setup may be familiar to you. So the person lies with the head slightly elevated, wears a goggle which records eye movements, and the operator puts some hot, sort of warm or cold water or air into each ear. And then the test may take up to 40 minutes. And if you have a concentration lapse, then the test may be invalidated, so then you have to do the test again. So it's a very tedious test. Now, so why are some of us, or a lot of people, still ordering caloric testing? Well, it's a time-honored test. It's been around for more than a century. You can irrigate each year at a time, and that's been taunted as one of its advantage. The subject or the person having the test doesn't need to move his or her head. And this last point is of interest because from the last few years of research, this may be the most abnormal test in Meniere disease, but there's a qualifier in it, and I'll come back to caloric testing compared with other vestibular function tests. Now, what about a disadvantage? Well, it's very time consuming. It takes a good 40 minutes. It's very uncomfortable. For those of you who had it, it's not uncommon for the person to get nausea and or vomiting. Now, as you've seen from the previous slides, there are three canals, so there are three sensors in the rotational planes, and caloric only tests the horizontal canal, this one here. So it doesn't probe the function of the two other canals. It doesn't do that. And the other major factor is it is heavily depending on the person's state of mind. For example, if they took Stemetel before they had a test, the test may be invalidated. And the operator needs to take great care because the test is easily contaminated by technical factors. Now, so we now have the video head impulse test, and Professor Kerthwaite is behind the invention of this test. And I think this is going to change how we look at vestibular function tests in Meniere's disease, especially during an attack, because you couldn't imagine putting someone through caloric testing during an attack of Meniere's disease. You couldn't do that. The person's already vomiting. How could you get them to have caloric test? And then I'll touch very briefly about VAMP. And so most of you, and some of you may actually have had this test, the head impulse test. It relies on a very simple fact that the balance reflex, the vestibular ocular reflex, maintains the eye so that it stays fixed on the target of interest. So in this picture, the examiner rotates the person's head to one side, and if the person is asked to look at the examiner's nose, the eyes stay fixed if the balance reflex is intact. Now, if the balance reflex is not intact, you can see that the eyes in panel E are transiently taken off the target, and then the eyes come back to look at the examiner's nose with their catch-up movements. We call that catch-up saccades. Now, the most immediate thing to take from this is, well, this is all good, but it depends on the human operator, the examiner's perception of whether something's happening or not. Can we record it, just like we can get a hearing test and document hearing losses across different frequencies? Can we record this? And so the last 20, 30 years, am I correct? 30 years, Professor Kerthwaite's lab has been focused on developing technology that enable us to record a head impulse test. And when it started, it was very uncomfortable because back in those days, we didn't have the technology. The video technology wasn't mature, so we had to put contact lens on the subject's eye and record the eye movement. And you can see this is a tracing from a typical tracing from an example. So at the top left-hand corner here, you get two traces. You have a yellow trace, that's the eye, and the head. Now, during the head impulse is this slope up here. If the eye and head move opposite to each other, then the ratio of that is 1-to-1 exactly, and the tracing is being inverted. On the other hand, if you got someone here on the right who has vestibular neuritis, so they've lost balance function in one ear, then you see that the blue trace represents the head movement, and then you'll see that the yellow trace represents the eye movement. So the eye doesn't actually catch up with the head until later, where these step-like eye movements called catch-up saccades bring the eye back into position. So that's the premise of the head impulse test. Now, we now have the video head impulse test, and you've seen a slide from Payal's talk. The subject here is Hamish McDougall with one of the prototypes. The subject wears a lightweight goggle. It's usually a very light, I think 80 gram. And on the goggle, it's got a video camera which is capable of recording eye movements at a very high sampling rate. In the old days, such technology could only sample 60 frames per second. But as the technology matures, the camera can now capture up to 256, 512 frames per second, high fidelity recording system. And this is portable, so you could put it in your bag and test people on the road. And this has obvious advantage because traditionally vestibular testing means the person comes into the fixed laboratory. But now you can do this in a clinic, in anyone's office, in the emergency department. So portable rapid online test, a trained heading pulsar can do a pair of canals in less than 5 minutes, and you get the result straight away. The heading pulse is also superior over the caloric because you don't need to compare the response from each ear. And as I said, this measures the vestibular-ocular reflex, and the immediate impact of that is if you're giving gentamicin to intractable, severe Meniere's disease, you could actually track how much vestibular function has been affected by the gentamicin. So you don't end up giving them too much gentamicin. And one of the other beauty of this test is you can test the vertical canals, the two other sensors that cannot be tested by caloric. So I think this is revolutionized how vestibular function test should now be done in general, and also applies to Meniere's disease. Now, there are a few disadvantages which I see as not disabling, and I think this will come with our experience. So obviously, being a new technology, you need training. You couldn't just put the goggle on and start testing people and say, well, yep, I've got it. So there's a learning curve involved. Now, and the other thing is, how do you interpret the result? Well, that takes experience. You probably need to see hundreds, if not thousands, of normal and abnormal tracings to be able to see, okay, that is a normal recording, that is not a normal recording. Now, obviously, if the person has significant neck problems, so if they've had neck fusion, then you shouldn't be doing that video heading pulse, because this test requires movement of the neck. So that's probably the only contraindication. Now, some of the systems only record the right eye. There are 3 or 4 systems on the market. Some of the systems can only record one eye, so fixed to the right eye, for example. Now, that can be an issue. If some person has a glass eye, then obviously you get no response from that eye. But that's being worked around, as I understand. So that shouldn't be a problem in the future. Now, this I found very exciting, that you could actually test vestibular function during an attack of Meniere's disease. Now, granted, someone else needs to do the test, so it's not like home audiogram where you could test your own hearing at home, but I think this nevertheless represents a massive step forward, because someone could come up to your house and say, look, I'm having an attack 30 minutes ago, and sure, I'll come in and I'll do the video heading pulse test. And there are not many studies that have documented what actually happens to video heading pulse test result during Meniere's disease. And I'll give you a couple of examples. So in summary, the balance reflex, as measured by video heading pulse test in Meniere's disease, varies depending whether or not you've acquired it during the attack or in between attacks. So in between attacks, the result is usually normal, and typically the caloric test shows that year is weaker. So that the year with the hearing loss has the abnormal caloric test, but normal video heading pulse test. During an attack, like the hearing, fluctuating hearing you're getting with audiogram in Meniere's disease, the balance reflex fluctuates, which is really interesting. So here's an example of that. So this is quite a complicated graph, but for the purpose of visualization, the red curve is the good ear, the blue curve is the bad ear, and this is a 12-month follow-up period where the patient has been caught during an attack with video heading pulse test. And each grey bar represents an attack, and the width represents the duration of attacks. So you can see some attacks are shorter. Here, this one here is 2 hours, and some attacks here are longer. And you can see that during the attack, these numbers represent the gain or the function of the vestibular-ocular reflex. And 1 is taken to be normal, less than 0.7 is taken to be abnormal. You can see that during the attack, the bad ear, the left ear, the ear in blue, the vestibular-ocular reflex dips, so reduces during the attack, and then recovers in between attack, and then following another attack, or during another attack, the number dips again. So you can see that in parallel to their hearing, the vestibular ocular reflex also fluctuates during their attack and recovers to near normal after an attack. And I think this is quite exciting finding. Now, obviously, to conduct a study like this would require an operator to be on standby mode, basically on their phone 24/7. And if they get a call, I'm having an attack now, and okay, I'm coming in 30 minutes, and do the test on the spot. But this brings up a whole new, I think, possibility of testing people with Meniere disease. And remember, the test only takes 5 minutes to do. So you're not subjecting the person to a 40-minute marathon of caloric testing. Now, the Koreans have taken this further, so they've looked at a couple of things. They've looked at the relationship between caloric testing and video handling pulse test between attacks. And most of their patients, so this is a person here, I'm not sure if he's projecting quite well, but if you look at the horizontal canal up here, you can see the eye trace in red and the head trace in blue. They don't quite match up. So there's a deficit of the eye movement in response to head rotation. So there's a reduction of vestibular ocular reflex for the right horizontal canal. And that matches up nicely with a caloric canal weakness on that side. But this is not the usual pattern you see in Meniere disease. Most people with Meniere disease have the second pattern where the heading pulse test results are normal, and in the bad year, you get a caloric weakness in the opposite year. You can see that here. So this is now, we think this is a typical finding of Meniere disease not during an attack, but in between attacks. And whereas during their attack, we expect the video heading pulse test to be abnormal. And then after attack, the video heading pulse test result recovers to baseline. So I think going forward, my view about the role of vestibular function testing in the future is that if you're testing someone in between attacks, you should probably do caloric and video handling pulse. And that discordance or dissociation between the two tests allows you to say, aha, well, this looks like Meniere's. There's hearing loss in that year, and the caloric is weak in that year, and the video handling pulse is normal. And if you have an opportunity to measure them, to measure the video heading pulse test during their attack, then you will see this. You see a loss of balance function, which then recovers. Now, I'm not going to talk too much about vestibular valve margin potentials, in part because Professor Kerthor is in the audience. But it is a test of otolith function, so the other graviceptive organs. The other organs in the vestibular system, very important. Now, I thought this is a bit disappointing. I found this is the American Academy of Neurology guideline. This is quite disappointing. Their committee met last year and said, on the basis of multiple conflicting or inconclusive studies, neither cervical VAM nor OVAM was found to be useful in diagnosis of Meniere disease. And that there's insufficient evidence that either test may be used to diagnose Meniere disease. Now, this is a committee of, I think, 12 experts, North American experts. So I found this a bit disappointing because clearly many research groups, including ours here in Sydney, have been looking at the utility of vestibular valve margin potential testing Meniere disease. And this doesn't mean we should stop doing research in VAMP. It only means, the score is not settled, and we have to do more research. And there are some promising research. So Leonardo Manzari's paper in 2010 showed that OVAM and CVAM may be differentially affected during an attack. Now, VAMP can be done during an attack. It's not a demanding test. It might be useful in monitoring the inner-ear vestibular status after gentamicin injection. And Rachel Taylor has shown that depending on what sort of stimulus you use, they do have abnormality on their VAMP. So I don't think the dust I don't think the score is settled for VAMP, but this is a bit disappointing, but I'm hoping there will be more research, and I'm sure there will be, in VAMP and Meniere's disease. So I think in conclusion, I still think caloric tests can be useful, but if you're going to do the caloric, you must do the video heading pulse, and that difference you get is what helps you diagnose Meniere's disease in between attacks. I think in the future, we have the capacity and the ability, initially in research setting, to do video heading pulse tests during an attack. And I think that's very exciting. Now that we have a high fidelity, portable technology that we can bring to the patients. And as I said, VAMP, the role is currently uncertain, but I'm sure more research will be done. In the future, we might be able to come down with what I call a battery of tests. So you do limited 2 or 3 tests during or between attacks to help you diagnose Meniere's disease. So I think in the old days, we would throw the books at the person. You know, the person often will be subjected to 2 or 3 hours of torture. I think those days are probably gone, and we'll, in the future, vestibular testing Meniere's disease will be very targeted. Thank you very much.
So I thought I'd just remind you all a little of the anatomy of the ear. I'm sorry I haven't got a pointer, but you should know that there's a bony shell inside your ear which contains both the vestibular apparatus and the cochlea. And this is a picture which is available on the net. I think that's from a book. I've got to be a bit careful. Inside that bony shell, we've got this delicate membranous labyrinth. It's like a balloon, if you like, that has the cochlea, the saccule, utricle, and the 3 semicircular canals. And that's full of substance called endolymph. And what happens in Meniere's is that we've found that people have that balloon, that membranous labyrinth, is blown out, and it's called endolymphatic hydrops. And this shows a picture on the right from histology with the scala media, which is where the endolymph is blown out. And you can see at the bottom a little diagram. So this was my diagram of that balloon, the membranous labyrinth. And we have the cochlea on one side, saccule, the 3 semicircular canals, the utricle, and then the duct leading to the endolymphatic sac. People said that originally they thought it was an IUD, but I promise you it's meant to be just a cartoon drawing of the inner membranous labyrinth. And what we know is that there are various sections to it. There's the endolymphatic sac, which in man, about 1/3 of it is within the bone, so it fuses in with the duct. Then we have the endolymphatic duct, which is incredibly narrow. Then we have the sinus, the endolymphatic sinus. Then we have the valve of Bast. Then we have the saccule. So you may ask yourself, why did God make it so complicated? It is, and I can tell you there's good reason why he did it. He knows everything. So what we know is that the most compliant or easily distended part of the ear is the apex of the cochlea. So if you get a little bit of extra fluid in the ear, the bit that blows out is the apex of the ear, which I've represented in blue, just to show where the hydrops is. So in Meniere's disease, the first place that gets endolymphatic hydrops is the apex of the ear. Hence, we get the low frequency hearing loss that fluctuates depending on how much fluid is present. Unfortunately, eventually in Meniere's disease, the whole ear will get blown out eventually, and the whole ear is affected by endolymphatic hydrops. So what we know is the endolymphatic sac is a very important structure. It's the only structure really that can remove excess endolymph. So you have too much endolymph, it has to be removed by the endolymphatic sac. It's immunologically competent. So it contains different things, macrophages, plasma cells, etc., that can destroy and remove viruses. Its job is to defend irreplaceable structures in the cochlea. So if a virus gets into the ear and it goes into one of the hair cells, then killer cells will come, it'll replicate the nucleus, and then killer cells, and it destroy those hair cells. So we don't want the hair cells that you hear with or balance with being destroyed. So the endolymphatic sac has a role in protecting the cochlea and the vestibular system. And controversially, so I put it in blue because it's just my own idea, it can signal the cochlea to make extra endolymph to flush noxious materials out of the inner ear. So if there's something in the inner ear, the sac can help signal to it, get more fluid into the ear and get rid of that fluid. So normally, and we know this from Alex Salt in the States, the fluid in the ear doesn't drain anywhere. It's just regulated by the blood vessels in the ear. So if an inflammatory reaction occurs inside the ear, and Dan's been doing this with some stuff he can inject into the endolymph, then the viruses or whatever lying inside the cochlea, then what happens is that we produce some hydrops, or hydrops is produced by the inflammatory reaction, and then it's drained into the sac. That fluid will move into the sac, removing all those noxious and horrible materials to the endolymphatic sac, where they can be neutralized and removed. So this is a very old theory of mine, which is still in dispute, but we formed it in 1991, that it was reflux of endolymph from the cochlea into the utricle during episodes of longitudinal drainage, which caused the attacks of vertigo. So what we're saying is that in Meniere's disease, the endolymphatic duct is contained in quite a tight bony canal. And when you get fluid in the, when the fluid tries to drain out of the ear, it can't get through very easily. It fills up the sinus and eventually blows back into the utricle, stretching the crista of the balance canals and causing the attack. So that's the theory. And then once it's drained, the hydrops is virtually gone, but unfortunately in Meniere's, some hydrops will remain in the cochlea and also in the vestibule. So then once you've got hydrops in the ear, little events that can cause a slight increase in the fluid in the ear might be enough to trip the longitudinal drainage mechanism, or at least make it drain again. So it could be eating a salty Chinese meal. It could be stress when your daughter gets her Visa card. But all these things might just increase the fluid enough to cause another attack, until it's drained down enough that you get a period of remission. So you have one attack, then you may have a series, then you have a period where it goes away. And we've got some backup of this idea from Dan in the lab, because they've been injecting things into the ear, and they can see that we're not getting ruptures in the ear, and that when they inject into the utricle, you do get changes in vestibular function. So that's some of the lab work. Now, we've known for years, and there's so many papers on this, I've only thrown one up, which is from Japan, that there are viruses have been found in the endolymphatic sac. And there's a lot of people who, like Gajcek and others, that feel that Meniere's is a viral condition. So the cause of Meniere's disease? No. The causes of Meniere's disease, there's probably many different routes that end up causing Meniere's disease, But the one we're interested in for this study is going to be whether it could be a virus or not that is the cause of the Meniere's disease. So what we're saying is that a viral labyrinthitis, like in an ear with a narrow aqueduct, ends up with the formation of endolymphatic eye drops. So for some reason, there's a problem removing that excess fluid and all the antigens, that's the products of the virus, into the endolymphatic sac. Can be structural, it could be a genetic deficiency, or it could be an immunological deficiency. And Stephen Spring's here, and he knows much more about the possibilities of the immunological deficiency than I do. And then you end up with the chronic eye drops. So the small fluctuations in the level of endolymph sufficient to activate longitudinal drainage and cause the attacks. Until the volume of endolymph drops below a critical level, and then you get a nice period of remission. So what's the cause of the recurrence? After a nice period, you think, good, it's gone away. We've had several weeks, months without it. Now it's come back. So either the virus has re-erupted within the cochlea, and we all know cold sores, for instance, that can re-erupt on the face, or an antigen, which is a structure of the virus, is bloodborne to the endolymphatic sac, and the endolymphatic sac then steps into action to ensure there's nothing harmful inside the cochlea. So this bottom one should be in blue. That's very theoretical. And the endolymphatic sac activates a mechanism to increase the endolymph in the ear and then to flush it out of the cochlea to protect the irreplaceable structures in the cochlea. Well, come on, move. Page down. Not moving. Sorry. Then what I want to go to next is to tell you the study that we want to do to prove whether or not, oh, well done, thanks. So we want to do a study to find out whether viruses can be involved in Meniere's disease. And we need volunteers, okay, or participants. We thought we'd better choose people who had Meniere's between the age of 30 and 70, because some of the younger people are more likely to have other things that could happen, like congenital things. That it should start with a nasty attack. The first attack should be a nasty attack, and they're still getting the attacks of vertigo. Then we have to find people who are willing to go to their local Douglas Hanley Moir, the blood people, and have a blood sample taken as soon as possible. I don't want people falling over or being run over by motor cars, but as soon as it's safe to get there, and they will take the blood and they'll treat it in a special container to send it to the University of Sydney, where virologists will check to see if we can find antibodies or viral particles in the blood. And then, because we're saying it has re-erupted during an attack, we want another sample a few weeks later when they're well, when they've gone into remission, so we can compare how much virus or antigen is present. And that would help us know what's going on. So we hope to be able to keep the volunteers informed. We'll let them know if we find any viruses in their blood, and we'll also let them know the outcome of our study. So first of all, we have to receive the name and address of potential volunteers. Then we're going to mail out or give you some more detailed information and the consent forms, which must be signed. On receiving the consent forms, we contact them. We ring them up. It'll either be Payal or myself. There's the three, and Daniel, we're the three that are the chief investigators. And then we ask them the questions, but the questions will be on the form that's sent out, so they'll know what questions we're going to ask. And then nothing then happens until they have an attack. Then on receipt of the first specimen of blood, we send out another form.
Any exclusions in relationship to comorbidities or current medical regimes like antivirals?
Yeah, well, if you're on an immunosuppressant, such as steroids, or you've got really bad rheumatoid arthritis, then that might spoil the study for us. So that is in our more detailed handout. I'm just giving you the basis of the study first. And then we thank them, tell them that we'll let them know the outcome of the study. So if successful, can we cure Meniere's disease? Well, we're just wondering if we could boost the circulating antibodies to that virus, if we find it, that the virus can then be destroyed in the circulation rather than reaching the endolymphatic sac or cochlea in sufficient levels to cause an increase in their endolymphatic hydrops. Now, I'm sorry that I may be very complicated. I try to keep it simple, but we are doing a live webcast, and if anybody wants to, we'll hand out this number. You can click on it, and you can go through any of the talks today if you want to hear or need to go into them in more detail. So thank you for listening to me. Now the bit you're probably most interested in is Dan's going to come up, and he's head of the laboratory, and he's going to tell us some of the new things that have come out of the lab which we definitely need to chase up in the future. Thanks.
Vestibular functional tests for Meniere's, because I'm going to cover a little bit of that today as well. And I also just want to talk, primarily this talk today is really about the research that we've covered in 2018. So in the last couple of years, we've had a bumper couple of years in terms of publications and new studies that we've started to conduct and have completed and published the results of. So they're the sorts of things I'm going to cover today. So this year, over the last year and a half, we've grown the lab team. We've included a newer member, which is Dr. Miriam Jackson, who's a molecular biologist, and I'll talk about some of the research she's been performing in the laboratory. We've also had Mr. Chris Pastras, there is the mouse there. Mr. Chris Pastras has finished his PhD studies this year, he's been a great benefit to the laboratory over the last 6 years. He started out as a research assistant in the laboratory for a year and then went on to conduct a PhD. And I'll talk about some of his results from his research, which have been published this year as well. We've also had Dr. Liliana Sokolik, who has been a research assistant in the laboratory for the last year and a half. She actually came from being a research assistant in Professor Ian Kurthwaite's laboratory, so she's got a wealth of knowledge in terms of handling the animal research that goes on. And of course, we've got clinical collaborations with Prof. Gibson and Payal, which they both talked about. And fortunately, we've had Ian Kurthwaite in the laboratory for a number of years. He's been probably a tour de force for supervising the sort of research that we've had in the laboratory, and has been essentially a wealth of knowledge and a guiding force for the sorts of research that we do as a team. He effectively brings together the whole Meniere's research team as a whole, so he's invaluable for that perspective. And of course, we're still based at the Brain and Mind Centre in Camperdown. We have increased our laboratory space over the last year and a half, and we have all the resources there that we need for the various forms of research that we have. So as I mentioned, this year in particular has been a bumper year. We've had 5 publications published. They've covered various things such as looking at our basic understanding of the peripheral vestibular system. And that's important from the viewpoint of understanding clinical vestibular tests. So the sorts of things that Luke talked about that are performed in the clinic and at the forefront of clinical treatment of Meniere's disease. They're great tools for the clinician, but they often come with a lack of understanding about what those vestibular functional tests actually represent in the periphery. So much of Chris Pastras's research has actually been focused on providing a better understanding of what those vestibular functional tests actually mean and why they indeed may be different in Meniere's disease sufferers. We've then also worked on new animal models of Meniere's disease, and I'll talk about those results specifically today as well. We've begun working on inner-ear pharmacokinetics. What I mean by that is we've been working towards helping us understand when we apply drugs to the middle ear. So when you go to a clinician, often they might give you a gentamicin or a steroid injection through your eardrum. We need to know exactly where those drugs go, because essentially you can just putting the drug into a bony middle ear cavity doesn't necessarily mean that that drug is going to make it to the cells that they need that need to be targeted in the inner ear. And indeed, over the last 5 years, a number of researchers, particularly Alex Salt, who we work with in the States, have highlighted that drugs don't diffuse very well throughout the inner ear. So all of these steroid injections and various treatments, chemical treatments for Meniere's disease and other inner ear disorders actually probably aren't very effective at all, not because the drug wasn't effective, but because the drug didn't actually get to the inner ear. So we need to now develop new types of drugs or new techniques that get the drugs to the parts of the inner ear that they need to get to. And so we've started working on inner ear pharmacokinetic research as well. We've started developing new treatments for Meniere's disease, which is, I think many of you would probably be pleased to hear. I'm not talking about great new chemical drugs or anything. It's essentially low-level treatments, but low-level treatment strategies for enabling us to get the drugs to better disperse throughout the inner ear. We've started to look at the biology of the lymphatic sac. So Payal talked about the clinical study where she and Adrian Mori have been taking out tissues from Meniere's disease sufferers' ears during ablative surgeries and looking at them histologically. We've started to, and she also mentioned the fact that we'd like to be able to look at the endolymphatic sac in humans, but that's actually really hard to do. That's where we come in as animal researchers. We can now take out the endolymphatic sac from animals, specifically animals that have been treated in certain ways to mimic certain features of Meniere's disease, and then look at the endolymphatic sac of guinea pigs to help us understand exactly what's going on at the cellular level in Meniere's disease ears. And then, of course, we've also started to develop some clinical research projects, such as the viral study that Prof just talked about. So on to, initially I wanted to talk to you and introduce Chris Pastras. As I said, he submitted his PhD in early October, and he's been working on furthering our understanding of exactly how the vestibular system functions. So when you go to get diagnosed for Meniere's disease these days, if you're seeing a relatively good clinician who has got a wealth of experience for specifically diagnosing Meniere's disease, they will perform a number of vestibular functional tests like Luke presented today. And some of those include the video heat impulse test and the vestibular myogenic potential testing as well. But we don't have and they're reflex responses. So they're responses of the eyeballs or the muscles that control the position of the eyes or the neck. So they're reflex responses. They don't truly represent what's actually going on in the ear. So if we see a change in those reflex responses, we're really kind of left to theorize about what could be underlying those changes in the reflex at the cellular level in the inner ear of Meniere's sufferers. So Chris has basically been, one of the advantages of using experimental animals is that unlike humans, in guinea pigs, we can actually surgically get into their inner ears. And in the case of Chris, what he's been doing, he's actually been removing their cochleas surgically, which allows him to get direct access to the vestibular end organs in a living guinea pig, which is heavily sedated, heavily anesthetized, and will not wake up. But this surgical access provides us a way to actually measure the function of the vestibular system in these animals, whilst we perform various pharmacological or experimental manipulations to better our understanding of what goes on in the vestibular system. He actually started out his PhD studies actually trying to better understanding the role of the vestibular efferent system. And this is I won't talk about what the vestibular efferent system is specifically, but it's a part of the inner ear that we have really no good understanding of what it does, other than to say that it does something extremely important in the inner ear. It's the brain sending neural signals down to the inner ear to control its sensitivity. That's theoretically what it could do, but we just don't know if it does anything at all. So what Chris started out his PhD studies doing was to actually electrically stimulate the vestibular efferents in the brain stem of anesthetized animals, whilst in the periphery measuring the functional responses of the cells and the nerves in guinea pigs' ears. And what he found was essentially he could it was very clearly manipulate the sensitivity of the peripheral vestibular system through this electrical stimulation. It was a great study, provided with a wealth of research and helped us better understand exactly how the vestibular system responds to bone conducted vibration and air conducted sound, but ultimately didn't provide him with the result that he wanted. But it was a good study nonetheless. And I'm hand waving there because it's not specifically about Meniere's disease. He then turned his focus more towards trying to better understand what endolymphatic hydrops, which is the bloating of the membranous labyrinth that Prof talked about, actually does to the vestibular system. So Prof talked about, and when Prof does electrocochleography in Meniere's disease, he sees an abnormal functional response, this abnormal nerve response and hair cell response that he records with a wire through the eardrum. Likewise, there's theories about what bloating of the membranous labyrinth does to the vestibular system to result in the abnormal vestibular functional results that Luke touched on today. And so by directly measuring the functional responses of the vestibular hair cells in anaesthetised guinea pigs, whilst performing various experimental manipulations that mimic endolymphatic hydrops, Chris was able to demonstrate that indeed you can increase or decrease or even increase the sensitivity of the vestibular system simply by hydrostatically displacing the vestibular epithelium. Now that's, if I can summarise what I'm trying to say there, is that he provided the formal basis or evidence to say that endolymphatic hydrops truly can by pressure, manipulate the sensitivity of the vestibular system. That sounds like a simple statement, and to Meniere's researchers across the world, we probably all would have said, oh yeah, that was always the theory, we always knew that. But there was never any evidence to suggest that that was the case. So no one ever had any evidence to say that hydrops per se, and the increased volume of the membranous labyrinth, can in any way affect the vestibular system. Chris has now been the first to provide that evidence, backing up all of those decades worth of theories. So it's very important from that perspective. His research is really important, but it'll be glazed over because everyone already thought that that was the case, and they thought that they already knew that, which I think is very disappointing for Chris. But he's nonetheless had really great success with his animal research. And now on to the animal models of Meniere's disease that we've been working on for the last couple of years. I presented some of this research at the last year's symposium, where we're basically halfway through gathering the data. We've now finished gathering all the data, we've analysed the results, we've published the paper, and it was published halfway through this year. And moreover, I want to talk about some of the other things that we're doing with these animals as well. So my animal research really is focused on endolymphatic hydrops, trying to understand and develop a theory about how endolymphatic hydrops can develop in animals, how we can diagnose it and how we can treat it. So Prof talked about some of the ways that endolymphatic hydrops can be induced or can develop, and the theories of how endolymphatic hydrops develops. One being this potential blockage of the endolymphatic duct, resulting in a lack of fluid being absorbed in the endolymphatic sac when you have some sort of challenge in the inner ear, resulting in a bloating of the saccule and potentially the utricle, and certainly of the membranous labyrinth in the cochlea. You've also got, what that also implies that you have to have an increased secretion of fluid into the membranous labyrinth. Well, that requires, where does the fluid come from? It comes from blood vessels primarily that line the cochlear walls. So those blood vessels have to become more leaky, which we know happens when there is some sort of ionic or immune challenge within the inner ear. When you have increased their permeability, water potentially, and I'm hand waving here because no one's properly demonstrated this, but the theory is that when you have an immune or an ionic challenge within the inner ear, those blood vessels become more leaky, and we think that water flows into the membranous labyrinth, causing Reiser's membrane and the whole thing to swell. And that's the theory. So you have to have two things occurring to induce endolymphatic hydrops. One is an increased, well, you can have two things occurring. One is an increased production of the water in the cochlea, and one is a reduction in the absorption of the water in the endolymphatic sac due potentially to a blockage within the endolymphatic duct. Researchers tried, there's several animal models out there for creating endolymphatic hydrops in Meniere's disease. The classic one, I'm not going to talk about today, is for researchers to go and get a guinea pig, surgically drill into the back of its skull. When it's under anaesthesia, it doesn't feel anything. It's a very small little drill, it's just a bit of bone. Guinea pigs are really robust. I mean, I've started to do these experiments thinking it was going to be really harsh. You anaesthetise the guinea pigs. It's a small slit, it's a small drill, you stitch them back up, they wake up, within 5 minutes they are fine. It's no different than many of the surgeries that we might undergo in our own lives. So it's not a particularly invasive or damaging type of surgery to these animals, but indeed it's extremely necessary for our understanding of Meniere's. But the sac ablation model of Meniere's disease in guinea pigs has been the mainstay of understanding how or the animal model of Meniere's disease. The problem with that model is that Meniere sufferers still have an endolymphatic sac. So it's not a true representation of a clinical model of a pathological entity. So other models have become enticing over the years. One such model is to put antigen, like parts of a bacteria or parts of a virus, into the inner ear of experimental animals. And lo and behold, when you put antigen into the inner ear, over the next couple of weeks, these animals start to develop endolymphatic hydrops. In some situations, they can develop a low-frequency hearing loss. And that's been demonstrated as a potential model that demonstrated that immune dysfunction can initiate endolymphatic hydrops. One of the problems with this simple model is that the endolymphatic hydrops in these animals tends to reduce or recover within about 4 weeks after putting the antigen into the inner ear of these animals. Now, there's been a couple of models where investigators have continued to pump the antigen into the inner ear, and they've said, oh, look, we can keep the endolymphatic hydrops going if we just keep giving them injections of the antigen, but that's not really a good model for Meniere's disease sufferers. There's other theories about what could cause the antigen to persist, or at least the immune response to an antigen to persist within animals, and Stephen's got various theories that have supportive evidence for having a genetic predisposition that makes a person not be able to clear the antigen, or rather be hypersensitive to when there is an antigen present within the inner ear. But within experimental animals that have been developed in the laboratory, there's actually not much been done in that realm. One of the things I also noticed that hadn't been done or hadn't been understood, people have basically been ignorant of, is the idea that antigen, so far lots of Meniere's researchers had put antigen into the perilymphatic compartment of the inner ear and provided and looked exactly how the inner ear clears that antigen from the perilymphatic compartment. And that's not really telling the whole story, because Meniere's disease is a bloating of the membranous labyrinth, and this sort of swelling, temporary swelling, is only indicative of probably changes in the permeability of the vasculature system surrounding the endolymphatic compartment. All of these models where they put antigen into the perilymphatic compartment provide evidence that there is a temporary endolymphatic hydrops. You have a gross, that results in a gross cellular infiltration. Immune cells flood into the perilymphatic spaces to gobble up and process and remove the antigen so that things settle down after a couple of weeks. And certainly that's been used to help us study and understand the dynamics of the immune system within the inner ear. However, one of the things that people had glazed over was, what is the role of the endolymphatic compartment in the inner ear in terms of processing antigen? Now, within the endolymphatic space, there are many situations where you might have cellular debris break off and float around in this space. You might have antigen like viruses, or foreign antigen like viruses or bacteria potentially make their way into this space. And within this space, the fluid called an endolymph is really abnormal. It's got a very, very high concentration of potassium, which is lethal to most cells. So the one thing you don't want happening is immune cells getting into that space to process and get rid of antigen. So one of the things that we haven't clearly understood is exactly how does antigen within the endolymphatic space get removed from the inner ear. Now, Bill had this theory of longitudinal drainage for many, many years, and everyone sort of just glazed over because they basically thought, and even I must admit, even when I came to first work for the Meniere's research team, Bill Gibson's drainage theory. I looked at it and went, oh, that sounds nice, but it's a theory, and all theories are, there's a million and one theories, but they lack evidence, and people still say the drainage theory lacks evidence. Well, this is fortuitously, in terms of doing, in the course of me doing this, this study where we've been placing antigen directly into the lymphatic compartment of guinea pigs, it seems that we have now proven, gone some way to proving Bill Gibson's drainage theory. Now, in order to, what we basically have been doing in these animals is to inject antigen into the endolymphatic compartment of the animals, stitch them up, recover them for either a day, a week, or 6 weeks, and thereafter we have to euthanize them very rapidly and without any pain. Then we take out their temporal bones, and we have a look at the temporal bones histologically. And rather than actually do the standard technique, which is what people do when they want to look at tissues, which is cut up tissues and put them onto slides and put them under a light microscope and then look down a powerful microscope at that one thin slice. Instead, we look at the entire inner ear using this technique called light sheet fluorescence microscopy. And what that involves is taking the entire temporal bone, chemically treating it to make it transparent to light, and then what we can do is create a very, very thin sheet of laser light that only illuminates one very thin section of this transparent temporal bone. And when you've only illuminated one very thin section and you look at this, that cross-section through the whole organ, what you see is essentially very similar to what you might see on a histological slide. But the advantage of this is you can move the whole temporal bone through the entire light sheet and build up an entire 3D image of what is going on within the inner ear. And that's very important for the inner ear because a really complex structure, histological sectioning does not work very well because it damages and morphs things like rhizome membrane, it creates lots and lots of artifacts, and is very prone to researchers picking and choosing exactly what slide they want to use for their research output to provide support for their own theory. When you do things in 3D, you remove all of that biasing, that user bias. Anyway, on to the results. So, as I said, the project involved injecting antigen into the endolymphatic compartment of guinea pigs. But first we need to do the control experiment, which was to just inject artificial endolymph into the endolymphatic compartment. So we're not injecting antigen, but we just have to go through that control step of just say, what if we just inject fluid first off? And what we see is that hardly anything changes within the inner ear. So here's the cochlea, and we've been primarily focusing on the cochlea and the endolymphatic duct and the endolymphatic sac of these guinea pigs. And when we inject artificial endolymph, we certainly don't see any evidence of endolymphatic hydrops, so I'm not sure how well this shows through. But this membrane here is what we're looking at in the cochlea called Reisner's membrane. And with endolymphatic hydrops, this would be displaced outwards. But in these guinea pigs, it's nice and taut, it's exactly where it should be, and there is no evidence of endolymphatic hydrops in these guinea pigs. Their endolymphatic sacs look really normal, and the endolymphatic ducts are their typical very, very narrow cells. So the control experiments demonstrate that the surgery and the experiment itself does not induce any unwanted outcomes. Then we moved on to putting the antigen in the perilymphatic space. Now, others have done this, and indeed the results we found pretty much align with what they find, is that we tend to see sometimes we see a mild displacement of the membranous labyrinth, but not much endolymphatic hydrops. We see cellular infiltrate in the perilymphatic spaces, and often we see a little bit of fibrosis in these ears, but not a lot going on after about a week, and certainly not much going on after 6 weeks. So these animals don't have chronic endolymphatic hydrops, even though they often do have evidence that immune cells are flooded into the inner ear to get rid of the antigen. We then stepped over to putting the antigen in the endolymphatic space. Now, I should point out that we actually dropped the concentration of endolymph that we'd put. So in the animals we put it into the perilymphatic space, we decided to put 10 times less of that concentration into the endolymphatic space to see what would happen. And that would result in 0.1% lipopolysaccharide, very, very small volume injections, 0.4 microliter injections, and then recovering the animals for a day, a week, or 6 weeks. And these are just representative examples. Lo and behold, we didn't expect things to be so severe. Now, you'll see here that basically once you put the antigen in the endolymphatic space, you get massive amounts of immune cells just flooding into the inner ear, destroying everything. These animals are functionally deaf, and they have huge endolymphatic hydrops, but they also have massive amounts of cellular infiltrate and even evidence of ossification throughout the inner ear. So these guys did not fare well, even though we assumed initially we were putting very, very, very small amounts of antigen into the endolymphatic compartment, much less than what we would put previously into the perilymphatic compartments. That demonstrates that the antigen, when antigen makes its way into the endolymphatic compartment, the immune response is much, much more severe. One of the other things we noticed as well was that the endolymphatic duct in these ears was not blocked up like we had assumed it might become, but indeed quite the opposite had happened, and that it was swollen. So the endolymphatic duct, when you have this very large endolymphatic hydrops, actually bloats and increases in volume. Now, there's a whole bunch of other results here. I'm skipping forward to say, okay, because we started to work down the concentration until such level time as that we didn't have this huge influx of immune cells. We basically ended up with a result that with a 20-fold reduction in concentration of antigen applied to the endolymphatic compartment. We now have the situation where we can induce severe endolymphatic hydrops in these animals after 6 weeks with very minimal to no cellular infiltration. That's the result that we were actually gunning for at the start, and it's the result that we got, because we wanted to have an animal model of chronic endolymphatic hydrops of at least 6 weeks with no fibrosis or cellular infiltration, because that's the sort of thing that we see in Meniere's disease sufferers. Meniere's sufferers don't have significant amounts of immune cell infiltration into the inner ears and ossification, etc., etc. For all intents and purposes, they just primarily have an increased volume of the endolymphatic compartment. Indeed, in some cases you do have a bit of cellular infiltration, but often that wasn't the case, and the endolymphatic hydrops does seem to increase from 1 day to 6 weeks. So there does seem to be an ongoing increase in the volume. The endolymphatic duct in these animals wasn't always the same. In some animals it was enlarged, in others it was its usual narrow self. One of the things that we did notice is in many cases, particularly within a day of putting the antigen in the endolymphatic compartment, the endolymphatic sac secretes this glycoprotein that blocks up the entire endolymphatic sac and most of the endolymphatic duct as well. And now that's important for our research, and others had already been known, but this provided yet another example of this sac secreting this substance into the endolymphatic duct. And we think that's really important. It's one of the things that we're starting to focus on as well. We then started, so not only did we have a look at those slices, we also did 3D volumetric analysis of the structures. Now, which is really nice. People that do slice histology can't do that. One of the disadvantages of having a really nice microscope that can take lots of samples to a structure is that you then have to go and actually manually process all of these volumes. And we ultimately had about 56 temporal bones, and you had to then go through and with 1,000 images per temporal bone, and in each temporal bone you had to go through and by hand draw out all of the different regions of the inner ear. And doing a 3D reconstruction of each of these compartments took about 3 hours each one. So that was a task that I wasn't going to do. I was able to actually get a summer research scholarship and student and say, here you go, here's a bunch of data on a computer. Your job's to sit in a dark room for 8 weeks and analyse it. But he did it, and he did a great job, and it provided us with the volumetric data that we needed to support the suggestion that, which was obvious in looking at the images, that the endolymphatic volume is increased after 6 weeks in the animals that have been treated with 0.01% polysaccharide. The problem with this animal model, though, is that the hearing loss is still quite severe. So even with the lowest dose of antigen that we'd used, the animals still had a fairly severe hearing loss. Many of them didn't have any sort of cochlear function. And so even though that histologically it looked like it was a good model of Meniere's, functionally it wasn't a great model. So we're probably still looking at having to either drop the concentration down a little bit more or look at exactly where we're putting that antigen, I think. And so we're still working on it, but it provided us a good model for developing, having a look at the structures and the histology of what is going on in the ear. Now I'm going to jump there. Here's just go through this slide. I may just skip it. It's essentially more evidence of the end-lymphatic sac and the end-lymphatic duct secreting this glycoprotein into the structure. And that's one of the things that we've been really interested in, is exactly what is involved because the sac, as we know, is really important in terms of Meniere's disease. Its ability to secrete glycoproteins into the luminal opening of the duct is really fascinating. Where the glycoprotein is generated and secreted from isn't exactly clear, and what the cellular mechanics are of that process are also not clear. So one of the jobs of Miriam Jackson to do in our laboratory has been to actually take out the end-lymphatic sacs of these animals and actually start to understand through quantitative PCR and molecular biology techniques what's changing in the tissues that line the end-lymphatic sac that induce that secretion of glycoprotein into that lumen. Because we think if we can start to understand the cellular processes that are going on there, we may be able to develop new therapies that target that cellular secretion of the glycoprotein, because we actually think that some cases of Meniere's disease may actually be an abnormal production of that glycoprotein, and if we can dumb down those processes, we may be actually provide a new therapy for Meniere's disease. One of the other things that was interesting, but this idea that we're putting antigen in the ear was nice, but it's not all that simple. A much simpler process for getting this end-lymphatic sac to secrete glycoprotein is a much simpler technique where you just give animals glycerol. Now, this has been demonstrated many years ago, where you give an animal glycerol via an intravenous line, the end-lymphatic sac secretes glycoprotein, and then the glycoprotein fills the sac. There's theories that glycoprotein draws the end-lymphatic fluid from the rest of the cochlea up into the sac so that it can be further absorbed. And so rather than putting antigen in every animal and then looking at the molecular biology of the end-lymphatic sac, we decided to switch towards using using glycerol, intravenous injections of glycerol in animals, to help us understand what is actually going on at the cellular level in these animal models when they're secreting glycoprotein. In doing that research, which is what's been driven by Miriam Jackson at the moment, one of the other things that occurred to us was that this idea that glycerol actually triggers the sac to secrete glycoprotein that then absorbs end-lymph fluid from the cochlea may actually present us with a unique opportunity to actually increase the ability of drugs to perfuse throughout the inner ear. But as I mentioned before, that when we put drugs into the middle ear, so when a clinician puts gentamicin or steroids and they do these injections through your eardrum, that drug does not diffuse very well throughout the entire inner ear. It tends to just essentially sit on the round window. If it does get through the round window, it permeates very, very locally, and there's not a very large diffusion of that drug throughout the inner ear. But we know that as far as steroids are concerned, one of the areas that we want those steroids to be getting to is the end-lymphatic sac. And indeed, there's been a number of surgeons over the last 2 years have actually taken the approach of, when they're doing surgically accessing the end-lymphatic sac in Meniere's patients, and actually injecting steroids directly into the end-lymphatic sac, and the outcomes of those studies have actually been quite positive. Unfortunately, doing sac surgery is not something you can do in your clinic. It requires surgery, it's quite invasive, and it's probably a technique that you don't want to undergo. If we could circumvent that approach by using glycerol to actually attract fluid towards the end-lymphatic sac, potentially carrying the steroids from the middle ear with it, we may be actually able to get more steroids towards the sac and provide a better treatment. The nice thing about this is that clinically, many of these patients are already given steroids and they're already given glycerol. We just have to give them together. And that's like a no-brainer. Simple clinical technique to do, already FDA approved. The nice thing is, another additional fact of this is that the only other situation where people are given both steroids and glycerol together is in many meningitis. So in cases of meningitis, patients often lose their hearing, and one of the therapies has actually been to give both steroids and glycerol together, and in those clinical studies, patients the treatment was safe, and actually they had better hearing outcomes. It wasn't understood why they might have better hearing outcomes, but we think that potentially this idea that glycerol is somehow changing the pharmacokinetics of the inner ear might have something to do with it. So we're now starting to focus on this. And it would be really advantageous as well, because steroid treatment for the inner ear for Meniere's disease is on the rise. Many of you would have heard about various studies that have been done by this company called Autonomy. They've essentially done several large international phase 3 clinical studies of dexamethasone as a therapy for Meniere's disease. The company was booming, and then all of a sudden the results of their first phase 3 clinical study came out saying that they didn't reach statistical significance, suggesting that their clinical treatment of putting dexamethasone onto the middle ear didn't work, and their share prices plummeted. And everyone went, oh, it doesn't work, steroids don't work. Oh well, move on to something else. The company actually had 2 other studies on the go, and those other studies have actually started to now demonstrate statistically significant effects, demonstrating that steroids do actually provide a benefit for Meniere's disease. It's a fairly routine clinical surgery, and certainly in Europe, a lot of surgeons are starting to head towards providing steroid injections as a means for treating Meniere's disease sufferers. Unfortunately, not all Meniere's sufferers are the same. Some Meniere sufferers benefit greatly from steroid injections, and others, it doesn't do very much for them at all. I suspect that one of the reasons for that variability may actually be that individual sufferers have different pharmacokinetics. The drug's not going to diffuse the same in every person's ear. Some people have big ears, some people have thick membranes, some people have all sorts of different anatomical reasons why drugs will not diffuse as well in one person versus another, and that variability may be the reason why steroids don't work the same across all sufferers. So if we can either work on techniques that allow steroids to diffuse better throughout the inner ear, and what people are starting to look at currently as well in America, is to try to come up with different drug formulations of steroids that allow those steroids to actually diffuse better throughout the inner ear. Because steroids, by their nature, are either water permeable but don't last very long in tissues, or they're water impermeable, so they're gels, and they sit on the tissues for a long time, but they don't diffuse very well and they're not very effective. So we need to actually work on the pharmacokinetics of those drugs, and I think that's going to be a great avenue for the next 5 years for Meniere's therapy. But I wanted to discuss more this idea that glycerol can induce this flow of end limbs. The first evidence we had of this actually occurring was through a series of experiments where I was injecting a fluorescent marker into the endolymphatic space of guinea pigs, and happened to be giving them intravenous glycerol as well. And what I found was this huge uptake. Here's the cochlea of one animal. The fluorescent marker went all throughout the membranous labyrinth, but there was this huge uptake of the marker up into the endolymphatic sac. And I never ever saw this in animals where I didn't give them glycerol. And this was the first sign to me that there is absolutely something going on with the drainage of the endolymphatic sac post-glycerol therapy in these animals. Now this marker was, as I said, I was injecting it directly into the endolymphatic compartment. That's not a great mirror for putting steroids into Meniere sufferers, because we don't put steroids into the endolymphatic compartment of humans. We're stuck with putting the steroids directly onto the round window, which is a very different compartment. So then I had to actually ask, well, okay, what happens if I put the fluorescent marker on the round window in the middle ear of these guinea pigs and then give them glycerol? Lo and behold, the same sort of effect was seen. Here's an animal where I have put the fluorescent marker on the round window. Again, it's taken up throughout the cochlea, but it doesn't, without glycerol, it doesn't really get taken up into the endolymphatic duct or endolymphatic sac. When I put the marker on the round window and give the animal glycerol, there's a greater diffusion of the fluorescent marker throughout the cochlea, and there's this large uptake of the marker into the endolymphatic duct and endolymphatic sac. So I'm sort of starting to further this idea that we can use glycerol to get steroids towards the endolymphatic sac. But this is a fluorescent marker. It's not a steroid, its pharmacokinetic properties are very different than what you might see from steroids. So then I had to step over to, okay, well, how am I going to look at steroid diffusion throughout the inner ear with glycerol? So I started using fluorescently tagged dexamethasone. So here's some preliminary results I have from guinea pigs, where I've got fluorescently labelled dexamethasone. I've applied it to the round window of these animals, and I've given them intravenous glycerol. Now in animals where I I don't give them glycerol, here's where the steroid goes throughout the cochlea. It doesn't diffuse very well, which is sort of in line with what other people have suggested occurs with dexamethasone. And there's almost no dexamethasone coming up into the lymphatic duct and lymphatic sac. But when you give the animal glycerol, the steroid seems to diffuse better throughout the cochlea, and there is a bit of uptake of the steroid into the lymphatic duct. Not much being taken up the lymphatic sac in this, but this animal was basically terminated about an hour after putting the steroid onto the round window. So I think if I'd left it for a bit longer, given it a bit of more glycerol or something, I could have actually seen a bit better diffusion of the steroid up into the lymphatic sac. Now, this I think is a simple approach to providing a better therapeutic advantage for Meniere sufferers. It's certainly one that I know that there's a couple of clinicians have already tried and tested around the world and have actually anecdotally suggested that their patients do better with the steroid injections. So they've already been giving their patients steroid injections. They started to add on get the patient to drink glycerol at the same time. And anecdotally, they've said that actually those patients seem to be doing a lot better than just the steroid outcomes alone. But that's not a clinical study, and anecdotal evidence is worth nothing in the scientific community. As I mentioned, one of the other things we're looking at as far as the glycerol treatment is concerned is looking at the molecular biology of the lymphatic sac. So what goes on in the cells of the sac to secrete glycoprotein or to help increase the absorption of fluid. The reason we want to look at those mechanisms is because we want to target therapies to actually manipulate the role of fluid absorption, fluid regulation in the lymphatic sac, and we're only going to do that if we understand what's going on at the molecular level. Sounds technical. One of the biggest hurdles of that particular study has been surgically getting out these wincy, tiny little bit of floppy tissues from the lymphatic sacs of guinea pigs. Payal talked about the difficulty she has in surgery of getting tissues out during labyrinthectomies in Meniere's patients. Guinea pig ears are about 10 times smaller, and the lymphatic sac is a really small structure, and it's adhered to the dura mater and blood vessels and all these other things that you don't want when you're trying to look at specific tissue. So one of the biggest hurdles for this research has actually been to develop the surgical approach of taking out the lymphatic sac of a guinea pig. Not the simplest thing to do, but certainly necessary if you want to actually study the lymphatic sac. And so I've already mentioned this particular novel adjunct therapy of glycerol and steroids is something that I'm currently looking at and hoping to pursue moving forwards, not just in the laboratory, but also in the clinical setting as well. So we'd hopefully within the next year start up a clinical study to actually look at the outcomes of intratympanic dexamethasone injections combined with glycerol therapy as well. With that, I wanted to, here we go, yep, right on time. Thank you very much for coming today, and thank the Meniere's Research Fund for their ongoing support of the laboratory, and also want to thank to Garnet Pass and Rodney Williams Memorial Foundation as well, who have been a great supporter of the laboratory as well. Thank you very much.
Introduce Bruce Kirkpatrick, who has been the driving force behind MRFI for many years, and really has helped us to establish the laboratory and to raise the money that's necessary for the whole project to continue.
And I want to cover just half a dozen points. The first one is to say how much we appreciate you all coming along here and supporting the team and their research work. Secondly, I'd like to refer to the funds that we have accumulated. We have built up quite a reasonable fund, but we still need more support. As you can see from what's going on, there is a lot of money that has to go out into funding equipment and people to keep this research going, and the research itself keeps weaving into new and exciting channels. So funding is important, but we do see some forces looming which are quite promising. Garnet Pass, as Daniel mentioned, has been a major supporter, and their continuing interest is very important to us. But equally important is your continuing interest. We need all of you continuing to support us. Thirdly, looming is some organisational change in Meniere's, with the arrival of Chris Patras into a more formidable role than he's had in the past. So when changes take place, be excited, don't be worried, be supportive. It's your support that we really rely on. And I am, fourthly, very excited by the changes and the new experiments that are taking place, to which Bill referred. I think we will be able to put together some very interesting results if we get the support from Meniere's people. Juliet, very early in her Meniere's problem, volunteered to have a syringe stuck into her eardrum and into the cochlear area, which alarmed me. I wondered what was going on, but it was an important contribution to helping Bill and his team find their way further down this path. This brings me to the fifth point, which is to again reiterate the need for your support. Your support, and this means people being prepared to volunteer to have their blood sampled so that we can continue these experiments. And we are continuing our role. Juliet and I will give another $250,000 to this research fund to help this particular aspect in this coming year. But finally, I would like to thank the team who spoke to you this morning so fluently and colourfully with these new ways of producing power presentations entirely beyond me. I follow them with admiration, but plead that nobody ever asks me to produce one myself. But finally, not only thanking the team, but thanking you all again for your continued support.